Good afternoon, everyone. This is Xandra White, Public Health Analyst from HRSA's Office of Quality and Data within the Bureau of Primary Health Care. Thank you for joining us today for this audio conference entitled Documentation, Paper and Electronic, the Basics and Beyond. Here at HRSA, we continue to listen to your feedback and suggestions on risk management, quality, and accreditation needs. Today with us, we have our partners, Keystone Peer Review, also known as KEPRO, and the ECRI Institute, who look forward to meeting your risk management needs by providing topics that will enable you to enhance your provision of services. I will now turn the presentation over to Amy Goldberg-Alberts, Program Director for the ECRI Institute, who will lead us through the broadcast. At the end of the broadcast, we will be available to answer your questions about this topic. Thank you again for joining us. Amy?
Thank you, Xandra, and thank you, everyone, for attending. I'm Amy Goldberg-Alberts, Director of the Program of Clinical Risk Management Resources provided on behalf of HRSA here at ECRI Institute. I'll begin with a couple of words about KEPRO, a quality improvement and care management organization founded in 1985 and headquartered in Harrisburg, Pennsylvania. KEPRO selected ECRI Institute to provide you free clinical risk management resources. KEPRO works with HRSA on medical malpractice claims reviews and risk management services under a contract initiated in 2004 and provides risk management and patient safety technical assistance to Section 330 FTCA deemed health centers and free clinics. ECRI Institute, an independent nonprofit applied research institute, over the past 4 decades has helped thousands of healthcare organizations across the nation develop patient safety, healthcare quality, and risk management programs to improve patient care. We're an evidence-based practice center designated by the U.S. Agency for Healthcare Research and Quality, a World Health Organization collaborating center for patient safety, risk management, and healthcare technology, and a federally designated patient safety organization. Over half of all of the HRSA grantee organizations throughout the country have now activated their user IDs and have set up passwords so that they can access the full suite of clinical risk management resources being made available by ECRI to you free on behalf of HRSA. This website contains risk management guidance articles, sample policies and procedures, risk assessment tools, educational courses with CME credit, and other resources to make your jobs easier so you can learn from others, customize to your own organization's needs, and basically not have to reinvent the wheel. You'll hear us refer to this website throughout the program. You can read about all of the resources offered, and you can log in from www.ecri.org/clinical_RM_program. User IDs were sent to each grantee organization, but keep in mind that an unlimited number of individuals at your center can obtain user IDs to access the materials. If you have not yet activated your user ID, please email us and we will resend the instructions to you. Our email address is on slide 3 in your handout in red, clinical_RM_program@ecri.org. With your audio conference registration confirmation, you received an email link to the slide handout. We hope you've had the opportunity to print or download the slides. Throughout this audio conference, we will refer to slide or page numbers in the handout so that you can follow along. This is our 5th in a series of Brown Bag Lunch audio conferences, all of which are archived on the website if you missed them live. About a month after each audio conference, we also post it as an e-learning course within the learning management system with continuing education credit available. So I also encourage you to take the course and obtain a certificate and credit. I'm pleased to introduce our clinical risk management experts for today's program. First, let me introduce Kathy Shostak. For those of you on our previous audio conferences, you already are familiar with Kathy's expertise in ambulatory care risk management. Kathy is a nurse with 20 years of experience in healthcare risk management, the most recent of which have been focused on patient safety and medical error prevention. She has risk management consultative experience within the medical malpractice insurance industry and management experience at the corporate risk management level of a large multi-specialty physician group. Ms. Shostak serves as Equity Institute's Chief Risk Management and Patient Safety Liaison to the HRSA-funded health centers and free clinics. Ann Gaffey, a guest speaker with us today, is President of Healthcare Risk and Safety Strategies, a risk management and patient safety firm that works with healthcare providers and organizations across the continuum to identify and mitigate risk through risk assessment and other engagements. She's a frequent speaker at national conferences and has published on risk management topics. Ann is a certified professional in healthcare risk management and a fellow of the American Society for Healthcare Risk Management, or ASHRM. Ann's also past president of the Virginia chapter of ASHRM and currently sits on the board of ASHRM, as does Kathy Shostak. So with that, I hand it over to Kathy.
Thank you, Amy, and welcome, everyone. Slide 4 contains the objectives for today's audio conference. We'll look at common inadequacies in documentation and strategies for overcoming them, general rules for reliable documentation, and special considerations for documentation using electronic health records. At the end, we'll open up the program for comments and questions, and we hope that you'll contribute your challenges and successes with documentation at your health center or clinic. On slide 5, it is noted that the medical record is both a medical and a legal document. Accurate medical records must be maintained in order to provide a record of medical care for the patient, to comply with legal requirements and meet accreditation standards and professional practice standards, and to support and defend the medical care provided. From a risk management perspective, the medical record serves as the basis for the defense of malpractice claims and lawsuits. Medical records which are poorly maintained, incomplete, inaccurate, illegible, or altered create questions of fact concerning the treatment given to a patient. Patients' attorneys often institute malpractice lawsuits when they believe the questions of fact created by incomplete and poorly documented records will cause a judge or a jury to find liability against a healthcare provider. According to data from the Physician Insurers Association of America, in the last 5 years, more than 8,300 closed claims reported diagnostic errors as the primary allegation. Inadequate documentation often confounds the ability to defend such allegations. On slide 6 is a case example involving documentation. A 50-year-old woman who died from a pulmonary embolism after visiting her primary care physician with complaints of shortness of breath and difficulty breathing. The patient had been seen on numerous occasions for the same complaint without any resolution. Continuity of care was complicated by multiple visits to different physicians, and the physicians kept a narrow diagnostic focus. The patient's record lacked a recent updated history and physical, though the chart featured multiple risk factors that could have pointed the physician in the direction of a pulmonary embolism. Expert review was unfavorable, and so the case was settled for well above $500,000. On slide 7, we'll see listed the top areas of risk in diagnosis-related claims. Claims involving diagnosis are among the most frequent type of liability claim involving health centers and clinics insured under the Federal Tort Claims Act. Inadequate documentation often contributes to these types of claims in the sense that the medical record does not support the diagnosis made by the provider, reducing the ability to defend the treatment provided. Medical record documentation was the highest secondary factor identified in claims reviewed by KeyPro during fiscal year 2009. Further analysis of malpractice claim data reveals documentation deficiencies with legibility, problem lists and medication flow sheets, and tracking systems for monitoring outstanding laboratory tests. On slide 8, key clinical components of the chart are listed. Organization of the chart contents is key so that important information is readily available and to avoid notes and reports from being lost or misplaced. Records should be organized into sections. For paper records, that means dividers that are labeled or colored, And for electronic records, that usually means tabs or easily identifiable screens. As a reminder, there are a number of sample forms for documentation available, including medication record administration, an office visit summary, consent for procedure and refusal of treatment, and other forms in the Sample Policies and Tools section of the Clinical Risk Management website. Moving to Slide 9, recommendations for general documentation are listed. Medicare's documentation guidelines for evaluation and management services establish parameters for the history, exam, and medical decision-making documentation required to justify billing for each level of evaluation and management service. They can also provide a framework for ensuring that patient records can support and defend the care provided. For instance, the first item, history and physical, is of utmost importance. According to a study just published in the journal Pediatrics, nearly half of the physicians surveyed cited a lack of information of the patient's medical history or a failure to review the chart when asked to identify the reasons for diagnostic process errors. While Medicare guidelines allow the review of systems and past history to be recorded on a form completed by the patient or ancillary staff, the licensed independent provider is required to enter a note indicating he or she reviewed that information. When medical history forms are supplied to patients or intake personnel to complete, it is important that the forms be reviewed. Documentation should reflect that review by the provider. From a patient safety point of view, the history and physical should not be delegated. When subsequent visits do not warrant a review of systems, there should be at minimum documentation by the provider indicating that the information was reviewed and updated. On Slide 10, we move to another important area for documentation, health screening. The failure to follow health screening recommendations or failure to follow up on abnormal health screening results, such as those indicative of cancer, are common factors contributing to medical liability claims. It is important that patients receive recommended health screenings and its prudent risk management for health centers to have and follow age-appropriate health screening guidelines. Health centers should establish protocols for health screening in keeping with the populations they serve. It is very important that medical record documentation reflect that recommended screenings were performed, and if they were not, why not? On Slide 11, we see that protocols can assist providers with decision support and documentation. For example, algorithms can help clinicians to assess patients for cancer risk factors, stratify a patient's risk for cancer, offer available screening tests according to patient risk and preference, identify advantages and disadvantages of each, and then document decision-making and follow-through. The Clinical Risk Management website includes links to algorithms available online for health centers to use in developing screening protocols. These resources can be found under Standards and Guidelines or by typing in these key terms in the search box at the home page. On Slide 12, along with a screenshot, we've included a link to the U.S. Preventive Services Task Force recommendations. Sometimes recommendations change or are in flux, such as the recent controversy involving breast cancer screening and mammography. The medical literature and risk management good sense says that providers should review new or revised guidelines, investigate the data behind them, and have informed discussions with patients that include information about false positives, and that there's no guarantee that a screening exam such as a mammogram will detect cancer. It's very important that documentation in the patient's medical record reflect these discussions and inform decision-making. Moving to Slide 13, we note important aspects of the patient exam, assessment, and diagnosis, and examples of clear documentation. The use of paper or electronic prompts to assess the patient and collect and document vital information can help providers ensure that they complete a thorough assessment or make and consider a diagnosis that is supported by a documented rationale and develop an appropriate treatment plan. It's a good idea to specifically document the patient's understanding of instructions Patient noncompliance may be related to a lack of understanding of the prescribed treatment, and it's a patient safety concern as well as a potential risk management issue. The medical record should reflect effective communication between the patient and family or between and among providers during handoffs. It should clearly indicate what information was provided to whom and what the follow-up will be. An example of complete documentation in the record of a pediatric clinic patient who presented with strep throat is shown on slide 14 as an example. It's comprehensive and the level of detail might not be needed in every case, but the documentation leaves little doubt about the history, assessment, diagnosis, treatment, and the plan of care. On slide 15, medical decision-making combined with history and examination is supported through problem identification, diagnosis, and treatment planning. Clinical risk management dictates that the medical record documentation be done in a way so that another provider reading the chart might reach the same conclusion. The notes should clearly support the provider's thinking and decision-making. Documentation should reflect what information, in addition to the history and physical, was reviewed and considered. In summary, medical record documentation should convey the diagnosis considered, diagnostic uncertainties, as well as management options considered. On slide 16, you'll see some titles with links to a series of online articles that might be helpful with documentation of patient history, exam, and medical decision-making in keeping with Medicare guidelines. Moving to slide 17, there are several strategies to assist busy providers with tracking and follow-up. We mentioned previously the use of decision support, such as health screening and patient care algorithms, that can help ensure that appropriate screening is performed, and that nationally recognized treatment guidelines, such as those available through the National Guideline Clearinghouse, are followed for disease management. A test results system can help track diagnostic tests by generating notices when test results are received, alerts when test values are critical, and by prompting clinicians to review results and take any necessary actions before the results are filed in the patient's record. An available tool, the Test Tracking Log for Physician Practices, is available in the Sample Policies and Tools section of the Clinical Risk Management website. Slide 18 lists strategies for test result management. The first is to standardize the methods used to collect and prepare specimens and to deliver them to outside laboratories. The second is to create and adhere to standard processes for tracking tests and for communicating with laboratories and other facilities. This strategy includes establishing a method for recording all tests requested, completed, and sent, as well as all results received. The clinic should designate an individual who will be responsible for finding out the reasons for delays if results are not returned within a reasonable time. Next is to establish a consistent means of responding to and documenting provider review of all test results. Although a computerized system is ideal for accomplishing this step, it may require nothing more complex than entry of provider-written notes into laboratory reports, which get date stamps after a copy has been sent to the patient. And lastly is to create the expectation that patients will be notified of all test results. A sample form, the Diagnostic Test Tracking and Follow-up form, that can be used to notify patients of test results and provide instructions for follow-up, is available in the Sample Policies and Tools section of the Clinical Risk Management website. Slide 19 lists system solutions to prevent failure to review and act on patient test results as part of electronic health records. These types of system solutions can help prevent breakdowns in communications that often accompany patient handoffs. The online resources listed on slide 20 are not scientific, nor are they endorsed by HRSA, KeyPro, or ECRI. They're simply provided as a practical help for health centers and clinics considering a transition to electronic health records. At this time, we'd like to conduct a poll to get a feel for how many health centers and clinics on today's call are using paper records, electronic records, or a combination of the two. Operator?
Thank you. At this time, we are ready to begin the polling session. There will be one question. Please respond by pressing star followed by the appropriate digit on your phone. You will hear a tone upon making your selection. please press star 1 if your health center or clinic uses paper records. Please press star 2 if your health center or clinic uses electronic records. And please press star 3 if your health center or clinic uses a hybrid of paper and electronic records. One moment, please. Once again, it's star 1 if you use paper records, star 2 if you use electronic records, and star 3 if you use paper and electronic records.
At this point, we'll review important documentation rules, and we're now on slide 22. The most primary rule is that documentation be legible. When entries in a patient record are not legible, they don't achieve the purpose for which they were made, to communicate information about the patient that can lead to errors and that harm patients and also increases risk. While electronic records help to reduce legibility problems, we're not there fully yet. Slide 23 shows an excerpt from an advisory publication of the Pennsylvania Patient Safety Authority on medication errors and uses an actual example from the Institute for Safe Medication Practices regarding ambiguity of an insulin dosing order. One problem often seen with insulin coverage orders is the clarity of handwritten orders from providers, a particular problem when a facility does not have a standardized protocol or order form to order insulin, including the type of coverage. Adding to the complexity of these orders are the multiple values often used for multiple ranges of blood sugars. Problems have also occurred when shortcuts are taken when writing these types of orders for insulin, as shown in the example. Orders have been written stating doses of insulin such as 6+1 or 6+2 instead of writing out 7 or 8. On slide 24, we begin with common sense rules for documentation that support reliable, credible medical records. Regardless of whether your health center is accredited, abbreviations that are error-prone should not be used. Links to resources on dangerous and prohibited abbreviations are included on this slide and include the Institute for Safe Medication Practices and the Joint Commission. Slide 25 lists the Joint Commission prohibited acronyms, symbols, and doses applicable to ambulatory care accreditation. Slide 26 notes additional documentation rules. With regard to telephone communication, documentation should be entered for telephone encounters with patients or their caregivers or with other care providers that provide new or renewal of prescriptions, alter the current plan of care, identify a new problem, or provide home care advice for symptom and problem management. Documentation should include the date and time of the call, the name of the caller, and the relationship to the patient if it's different from the patient, the response given, and the signature and professional title of the provider or the clinic staff handling the call. Some other important rules noted on slide 27 are to be sure to read any transcribed notes before signing them. That is because your signature is your legal authentication of the note. Special concerns with faxes are confidentiality and readability. The following event is an example of the risks of faxed orders. A faxed order for an echocardiogram resulted in the wrong test being performed and was a factor leading to the pulmonary arrest in a newborn who was scheduled for heart surgery to correct coarctation of his aorta. The fax was read by the receiving facility as an electrocardiogram. The infant suffered permanent damage, neurologically, physically, and mentally. There are also many counts of medication dispensing errors involving prescriptions faxed to pharmacies. In order to preserve data quality and protect patient safety, it is essential to establish and enforce a policy on proper error correction. Slide 28 reviews proper error correction procedures. Correcting errors in electronic health records should follow similar principles. On slide 29, notations to make in the patient's chart when a patient experiences an adverse event are listed. Documentation about the event in the record should not reflect that an event report was completed, but rather should contain factual information about the event and the care given to the patient. Slide 30 reviews what to keep out of the medical record, and that includes incident or event report forms, alterations, which should never be made in the record. All corrections, late entries, and addenda should clearly be marked as such in the record and be dated and timed on the day that they are written and signed. Disagreements among healthcare providers do not belong in the record. And records should not contain disrespectful comments about the patient, the family, or other providers. I recall reviewing a record with the term SC3 used by the provider to denote slow cerebration cubed, which was a sarcastic way of noting the low literacy and low educational level of the patient, but not an acceptable nor a professional way of documenting, and it shed a negative light on the provider when trying to defend the care provided in a malpractice claim. Slide 31 is a case example. You can read the clinical details listed on the slide later, but the crux of this case was a discrepancy over whether or not the patient received instructions by telephone to have kidney function tests repeated. Discrepancies in the record and allegations of a chart alteration reduced the record's credibility, and it contributed to a verdict for the plaintiff. Slide 32 reviews use of pre-printed forms and templates. Care must be taken that these methods support clinical care and accurate documentation, but are not simply to expedite the documentation process. At this point, we'll turn the program over to Ann Gaffey, who addresses the use of templates in her presentation and focuses on electronic health records and specific risks and patient safety concerns. Ann?
Thank you, Kathy. I'll begin on slide 33. In February of last year, President Obama enacted the American Recovery and Reinvestment Act of 2009, including the Health Information Technology for Economic and Clinical Health, or HITECH Act provisions. With the money dedicated to HIT, the ARRA envisions that all Americans' medical records will be computerized by 2014. Incentives totaling up to $44,000 through Medicare and almost $64,000 through Medicaid are available for each healthcare provider who implements EMRs and will be distributed on a sliding scale starting in 2011 and ending in 2015 for those who comply. After that point, the tables will turn, and providers who do not implement EMRs will receive up to a 5% cut in Medicare and Medicaid reimbursements. Noted on this slide is a link to the CMS site that further discusses the EHR incentive program. Moving to slide 34, we'll talk about what I call the elephant in the room. As technology is introduced into the patient-provider relationship on a regular basis, new skills will be necessary to ensure communication and documentation are robust. Providers, particularly those who are not comfortable working on a computer, will need training and support on how to bring this added element into the exam room. Good documentation is necessary to ensure patient safety, whether on a paper chart or electronically. Potential barriers to good documentation in an EHR can be the inability to demonstrate active listening techniques due to computer distraction. Providers haven't mastered the art of moving their attention from patient to screen and back, and appearing engaged and asking questions in response to the patient's communications. Having the ability to role play among staff prior to going live may help to sharpen skills and relieve concerns about this transition. Difficulty maintaining eye contact because of the need to look at the screen. Some providers feel they have to pay attention to what is on the screen in front of them, answering prompts and searching drop-down menus, which comes across to the patient as being distracted and not interested in what they have to say. Falling behind schedule because the EHR is slow to navigate. This barrier causes frustration to the provider, leading to impatience and at times just skipping over some documentation to move the process along and catch up. Computer too slow or times out too quickly. This barrier is another source of frustration, which when evident to the patient, adds discomfort to the interaction and could also lead to a provider skipping over some of the documentation prompts when an entry is not required. Continuing with potential barriers on slide 35, the lack of computer mastery skills, making it difficult to type and organize information efficiently, is another common barrier. These users have a different kind of frustration as they attempt to learn their way around a keyboard, searching for keys and navigating the mouse. Finally, while certainly not the last barrier, is difficulty structuring the interview around the patient's narrative. The logical inclination may be to structure the conversation around data-gathering demands of the EHR and not necessarily the flow with which the patient is presenting their concerns. During the EHR design and implementation process, it will be important for providers to understand their current workflow, how that flow may be altered with the implementation of EHRs, and how their communication and documentation practices may need to change. So, on slide 36, we'll go over some strategies for improving skills when using EHRs. In order for documentation in the EHR to be successful, the communication process must be effective to allow the provider to then enter the data collected into the electronic record. To accomplish this, a variety of strategies can be implemented to assist providers in expanding their skill set with the EHR. While there are several examples available, I will briefly review Connect, Collaborate, and Close. The first strategy, Connect, takes the provider through the process of bringing the computer into the relationship. This starts, as any encounter would, with a personal greeting, not by going to the computer first. The provider then introduces the computer to the patient with a phrase such as, "We are excited to be able to document your care electronically, as we believe it will allow us to be more efficient in treating you and allow us to share information more quickly. With this addition, I will be using the computer throughout our visit to document your concerns and my treatment plan." Acknowledge companions and address confidentiality. If a family member accompanies a teen, or if a spouse or significant other is in the room, assure the patient their information is private and move the computer screen in such a way that it can't be seen. Finally, when appropriate, arrange the screen in such a way that it can't be seen, or shared for viewing so the patient may see what is being documented and so that they may participate in decision-making by having the ability to review graphics and so on. On slide 37, the next strategy is to collaborate with the patient, specifically about the use of the computer. Providers should explain what they are doing, letting the patient know they will be moving back and forth between them and the computer to ensure everything they discuss is recorded for future care. Providers should ask permission to type and talk, and not assume all patients will be comfortable with this new practice. They should show the patient they are using information to share decision-making and not surfing the web. In a study by Baker and Keller of 39 videotaped doctor-patient visits with exam room computing, in the 302 times the clinicians turned to use the computer, only 43 times, or 14%, did the doctors explain why they used it. After the visit, patients who received no explanation frequently reported thinking that their doctor had been doing work unrelated to their clinical visit. So toward that end, invite patients to review the record along with them. And on slide 38, the final strategy is to close the visit. First and foremost, remove the computer from the interaction so the closing part of the visit can be specifically one-on-one with the patient. Log off to show them their record is secure. Providers should summarize the visit. For example, today we talked about your allergies and steps you can take on your own to treat them. Clarify what they are going to do, such as, before you go, you need to do A, B, and C, and say goodbye. Begin and end the interaction with the patient without interfacing with the computer. Now that we have spoken about how to bring the computer into the visit with successful communication, on slide 39, I want to talk about some of the risk management issues that arise as providers become more and more comfortable with using the computer to document in the EHR. The first and fairly common process is the copy and paste workaround. In most EHRs, there is the ability to go into a previous author's entry in the medical record, then copy and paste it forward into a new entry. We can all envision the myriad of problems that can come with this. The potential to perpetuate errors forward in the medical record, such as an incomplete or inaccurate history, documenting something as being on the wrong side of the patient, copying an incorrect medication or dose. You can see how far this problem can go. Other potential issues with copy and paste, noted on slide 40, include the resultant decision-making that could occur based on this incorrect or inaccurate information that a provider is using to make care decisions. The copying could have been accidentally placed in another patient's record or in the wrong encounter for the patient. A recent VA study published in the Cleveland Clinic Journal of Medicine found that 99% of progress notes in EMRs that were examined contained copied or duplicated text. 10% of almost 99,000 examined records contained an instance of what was considered high-risk copying. Beyond the obvious patient safety issues, there can be other implications, such as fraud and abuse claims when a visit is billed for, but the documentation is essentially the same as the previous visit or visits, and possibly from another author. Without going further into this risk management issue of fraud and abuse, a very helpful resource is noted on this slide from AHIMA. Moving to slide 41, I call your attention to templates and defaults. Templates can create efficiencies in the documentation process, and they provide prompts to providers so everyone is sure to ask all the expected questions when assessing and examining a patient. They are helpful to lead the questioning process, but when purchasing EHRs, providers should ask if templates are customized based on the users, for example, by specialty, or are they customized based on purpose, and are all the options providers seek available in the templates and drop-down menus they will be selecting from, for example, in obstetrics. A trainer for a Medicare administrative contractor recently stated that EMRs have led to cookie-cutter charting. He cited the example of an audit that asked the physician's office for 17 progress notes for specific patients on a specified date. When the charts were reviewed, 15 were essentially the same. Auditors, expert witnesses, investigators, and others find that lengthy notes generated by click box templates do not necessarily paint a picture, as well as short, free text notes. It is so easy to click a box, and for example, once a clinician has clicked the box for heart regular without murmur, or S3, the clinician cannot delete S3, even if he or she did not actually evaluate the S3. So it is possible that a clinician may not have carefully assessed everything that is included in a template's phrase. Some clinicians may be tempted to use free text. However, if the EMR has the option of using free text, and if its clinicians use it, then the analyses that are possible with EMRs cannot be done as readily. Clinicians must come to some safe middle ground between using free text and producing voluminous, meaningless records via templates. Some other additional potential pitfalls with templates and default documentation are noted on slide 42. An important finding can become buried in template charting. Providers need to have a heightened awareness of when defaults, which are when a particular documentation point defaults to a normal or abnormal finding, are in place. Providers should know if in the EHR they are automatically pre-populated with a normal finding and stay that way unless changed by the user, or if every field must be acted on by the user. It may be easy to inadvertently select the wrong patient from drag-down menus, and for those who may be using an EHR that interfaces with the hospital system, if hospital staff relies on electronic capture of physiological data, but a computer glitch occurs or the lead falls off, a long span of vital sign data could go unrecorded. On slide 43, risk management issues with CPOE are reviewed. Many improvements have come with the advancement of CPOE, particularly legibility, but there are potential risks that should be evaluated. For example, internal software mistakes, such as incorrectly using body weight in pounds to compute suggested dosages rather than the kilograms the software expects, could be present in the system. An EHR utilizing CPOE must have a method for calculating pediatric drug dosages based on weight, dose range checking, and age-based dosing decision support, none of which are typically present in adult medication management. There may be variations in effects of different systems. For instance, in one system, the allergy interaction system may provide feedback on allergies only after the medications are ordered. Standard-setting organizations have focused on broad CPOE functions, but they have not yet developed specifications for even basic best practices. For example, dosage displays may require the prescriber to enter a dosage into a fill-in-the-blank field, to which the system might respond with a reactive alert for the prescriber. And just when we thought we had solved the legibility issue, there are typewritten letters and numerals that are commonly confused. For example, uppercase letter S and numeral 5, or lowercase letter g and lowercase letter q. The goal of clinical decision support, such as alerts, is to provide the right information to the right person in the right format through the right channel at the right point in clinical workflow to improve health and healthcare decisions and outcomes. On slide 44, we see some of the issues surrounding alerts, which is an unsolicited, automated, triggered message about a patient's care or status that requires attention. The disadvantages to alerts are that they are unsolicited and thus possibly unwanted. If not carefully implemented to minimize false positive alerting, the user may experience workflow interruptions that can be annoying. An example is a notification about a critical lab test value, where certain specialties may have different thresholds, or a notification that an ordered intervention is contraindicated for a specific patient. Users are desensitized, and physicians get so many alerts they grow numb to the alerts and stop looking at them. In a study conducted by Singh, Thomas, Civic, and others in veteran affairs clinics, they found that 1 in 10 alerts for abnormal lab test results went unread by providers, and a large proportion of those patients did not receive timely clinical follow-up. The investigators found similar results when analyzing follow-up alerts and felt that alert fatigue was one possible explanation for these findings. While time doesn't allow us to venture deeply into this next topic, e-discovery is here and won't be going away. In finishing, slide 45 notes some important concerns. Whether you have a complete EHR or not, it is important that you have policies and procedures to address your organization's approach to e-discovery. In referencing above, metadata is the data about the data, or the information that is kept about the electronic files, for instance, who the author was, when the file was created, and so on. It is descriptive information that cannot be changed unless spoliation occurs. Electronic systems require the addition of an approach that includes information which does not fit a paper document model, such as databases, metadata, and so on. Disclosure may require data not traditionally considered part of the legal record. For reference, the federal rule number is provided on this slide. At this time, I'll turn the program back over to Amy, and thank you for your time.
Well, thank you, Anne. References for today's program are noted on slide 46, and an additional resource for documentation in electronic records is included on slide 47. In just a moment, we're going to open up the phone for questions, but before that, we will have another polling question so that we can get an estimate of the number of participants that are on the conference call. Operator, would you please give the instructions for this second polling question?
Thank you. At this time, we are ready for the final polling question. After the question is asked, please respond by pressing star, followed by the appropriate digit on your phone. The question is, how many people are sitting with you? Please press star 1 for 1 participant sitting with you. Please press star 2 for 2 participants sitting with you. Please press star 3 for 3 participants sitting with you. Please press star 4 for 4 participants sitting with you. Please press star 5 for 5 participants sitting with you. And please press star 6 for 6 or more participants sitting with you. Please vote at this time.
Okay. Thank you. Slide 48 is just a reminder that the Clinical Risk Management website contains guidance articles, standards and guidelines, and education and training materials that include numerous web resources to help you with documentation, electronic health records, and many other risk management and patient safety topics. If you have not activated your login and password to the Clinical Risk Management website, again, please contact us and we will resend your user ID to you via email. If you have already activated your user ID and you're the delegated access manager for your organization, remember, you can provide unlimited access to any individuals in your health center. The website address to log in, again, is www.ecri.org/clinical_RM_program. The dedicated telephone number is 610-825-6000, extension 5200, and the email address is clinical_RM_program@ecri.org. The very last slide in the handout for this program also lists all of this contact information. Reach us by email or telephone to have your user ID resent to you. Also, physicians and other providers can participate in the course documentation, paper and electronic, and they can potentially obtain continuing medical education credit for successfully completing by registering and logging on to the ECRI Institute eLearn system. This course will be available in the course catalog in just a few weeks. So now, operator, can you open up the line for comments and questions?
Thank you. At this time, we are ready for the question and answer session. If you would like to ask a question, please press *1. You will be prompted to record your first and last name. To withdraw your request, please press *2. Once again, if you have a comment or a question, please press *1 at this time. One moment for our first question.
Remember, we'd like to hear about and share your experiences, your challenges and successes with documentation and electronic records in your health center, so please feel free to make a comment or ask a question. I recall a commentary on the downside of electronic records. Another guest speaker that we've had, Dr. Richard Roberts, past president of the American Academy of Family Physicians, related a comment by a resident that went something like this. Oh, this is great. Now that we have electronic records, I can go home and do my charts at midnight. Well, doing charts at midnight is a practice filled with risk management concerns, not the least of which is that the documentation would be far removed from the actual encounter, increasing the likelihood of omitting information. But as Dr. Roberts noted, the never-ending day that is enabled by technology is also a recipe for career burnout.
We do have questions at this time. Our first question comes from Douglas Brody. Go ahead, sir. Your line's open.
Okay, on slide 41, your comprehensive documentation, there's nothing on there about documenting that the patient understands your instructions. What would you suggest?
Well, we did address that earlier in the presentation. I'm not finding the exact slide number, but that is something that we covered a little bit earlier prior to the electronic health record section. And it's generally, whether you're using paper or an electronic record, is certainly something that would need to build into the system, whether that's through your summary record, a note, or an actual form that you maintain a copy of that you provide to the patient with the instructions, which would probably be the ideal situation, so that you have an actual copy of what information was provided to the patient and whether they understood the instructions and are able to carry them out.
Okay, I guess I'm wanting to be more specific. On slide 13, it says document patient understanding. In the example of your comprehensive documentation on the next slide, there's nothing on there that says the patient understood. So you just put patient understands or patient verbalizes understanding? What would you suggest on that?
Yes, exactly. If you can just reiterate what the patient was told and whether or not they verbalize they understand the information that you provided to them. And also if you provide them with materials or literature or anything that may help them, comply, or additional instructions or information about their diagnosis, you might note that. And an easy way to do that would be to include an area to check off about that, or again, refer to some standard informational forms that you provide to patients that they did receive them, and they're able to read them and use them.
Okay.
Thank you very much for your question.
Mm-hmm.
Our next question is from Dr. Cupcake.
Hi. Am I open?
Yes, go ahead.
Hello? Yeah. One is very simple. I registered the last couple of days, and I never got copies of the slides, so how do I do that? That's question number one.
Okay.
That's pretty simple.
The slides will be posted at the website, but also if you just want to send us an email, we'll attach a reply and we'll send it right to you.
Great, because I didn't have a chance to have it in front of me right during the thing, so I'd imagine it. how do you feel about, that was just functional, having, we're at a center, we have a pediatric center, internal medicine side, and we're planning to get an electronic health record. I'm planning to bring up pediatrics first and internal medicine later because of computer issues. In other words, people are ready to use them or not. Do you see any problems with that?
No. Again, you're going to have to work with your vendor on planning. The planning portion of implementing electronic records is probably one of the most important. So if you're going to utilize for your pediatric clinic your electronic records first, it may in fact be a good way to test it for the remainder of the clinic. But again, work with your vendor and planning for that so that many of the areas that Ann mentioned with regards to embedding this work into your workflow, that it's not viewed as a negative. You need to engage the patients in using it, and and the patients' parents and families and so forth.
Right.
So I don't see a problem by doing it in stages. Many other types of facilities do it that way. But again, be sure to plan that out so that you can test it little by little, and it may in fact help you avert problems in the other areas of your clinic by testing it area by area.
Yeah, and also that way, yeah, and I also, just a comment, I know this is not number 2, but is that I feel that way I can work on the templates for peds, and then when that's working well, then I can concentrate on the other ones without trying to do both at the same time.
And this is Ann. That's an excellent idea because, as I mentioned, a lot of the systems out there are more related to adult management rather than pediatric management. So especially when it comes to weight-based dosing, that area, you really want to have a good conversation with your vendor about how that plays out in the record. And also identifying a couple of super users in your clinic who can be the go-to person, allowing time to implement and up-staffing a little bit. It takes some time to get a fully blown EHR implemented into practice. Generally, I think it's somewhere up to 24 months.
Yeah. Thanks. All right, I'm done.
Our next question comes from Aurelia Celestine. Your line is open.
Thank you for this most enlightening training. I want to know if you have maybe examples or samples of policies and procedures which address the electronic medical record?
That's a very good question. We do have guidance articles on the electronic health record at the Clinical Risk Management website. If you read through the guidance article on electronic health records, we embed links to available resources, which may include sample policies and procedures.
Great. Thank you. I'll do that.
Our next question comes from Dr. Marilyn Fudge. Your line is open, ma'am.
Thank you. Yes, I am at a community health center in Florida, and we are on electronic health record. And the scenario that you mentioned just prior to questioning in terms of getting the charts done and closed, I do feel that it takes a little while to get to the point of being comfortable with closing the charts when you're in the office because I feel like I'm putting in information but in saving it. However, I like to make sure I read through the chart as you suggested before closing it out. The problem is, and my question is as it pertains to a liability issue, what's the suggested limit in the time that a provider is given to close that chart? Should it be 24 hours, 72 hours, 7 days? Is there some issue, a liability standard that should be followed in terms of that?
Well, Ann, I'd welcome your comment as well. My thought, this is Kathy, is that most of our experience historically is with paper records, and your organization probably has to address that unique within your center. Once you get beyond 24 hours, the information that's in your head as a provider to put into the record, will fade because you're seeing additional, having additional patient encounters and so forth. I don't know of a specific standard along those lines for ambulatory care. That would be a good question to research.
Right.
The American Health Information Management Association, or AHIMA, it's just ahima.org. They have practice briefs freely available online that would perhaps address that particular question.
Okay.
I do think, what you're doing seems to help you be sure that your records are complete. But again, waiting that extended period of time to go back, if you're going to add information beyond that 24-hour period, perhaps, might be more like an addendum or a correction as opposed to a live entry.
Right. And we often have that same scenario where we have many providers that are unfortunately up at midnight trying to get those charts done and signed within that 24-hour. And I think it's because, unfortunately, during the workday, you don't really get enough time. You're trying to see patients in 15 minutes, and sometimes, obviously, with everything that goes on, that's not enough time. And that's one of the things we have set the 24-hour standard at our centers, but have been tossing that back and forth among the medical directors to figure out if there's any leeway on that. So I appreciate your input there.
And this is Ann. I'll just add one more comment. The other thing to keep in mind with electronic health records which is part of the metadata that I was discussing, is every entry that you make is going to be date and time stamped.
Right.
So it becomes clear, when that entry was made. I think 24 hours is a reasonable period of time, and I agree with everything else that Kathy mentioned.
Okay, thank you.
Thank you for your excellent question.
Thank you. I am new to the risk management position within my organization, and I believe, but I'm not sure, that our CEO is like the primary contact to set things up. How do I get that moved so that I can give access to ECRI to my providers so that they can access the e-learning and that kind of thing?
Sure. That's just a quick email to us. If you just send us an email with the name of your health center and your name and, however you want to get that changed, and your executive name, we'll just take care of that for you. So you can email clinical_RM_program @ecri.org.
Thank you.
Okay, thank you.
Thank you. Our next question comes from Linda Klein. Your line is open.
Yes, hi. I was wondering, sometimes we have some patients with mental health problems, and they will bring in, 10-page letters they've written to the doctor, not necessarily all that congruent, but the provider asks those to be scanned into the medical chart. I was wondering for advice on that.
This is Kathy. That certainly can be part of the record if the provider and the patient want that as part of the record. A guidance for including scanned materials in the record, I believe you'll find some specific information from the American Health Information Management Association, and that's just www.ahima.org. Okay. There are many free online practice briefs by that organization, and they do address specific record retention requirements and so forth.
Okay, thank you.
Thank you. Our next question comes from Brandon Fouch. Your line is open.
My question is, what is the best thought process, or how is, the way in which I can avoid writing or doing extensive free texting? For example, with the lab work, if a provider were to follow me and not understand why I had ordered a vitamin D level on, a male, and maybe does not know some of the current research, what's the best way to kind of avoid that, or am I kind of stuck with just having to do the free texting?
Ann, any thoughts?
I think the most important thing is to be able to communicate your decision-making process in the record, and it could be something that you could go back to your vendor and see what your options are. I'm presuming that you're using an EHR.
Yes, ma'am.
And see what the capabilities are within your system to add data related to orders that you're giving. But I think, frankly, the more important thing is that they have a clear understanding of your thought process. So it may be unavoidable, but see what your vendor can offer as far as solutions for some of that.
Thank you, ma'am.
Thank you. Our next question comes from Lori Pritt. Your line.
Hi, I just was wondering, I do have my logon and password. I'm wondering if we can just have a general company logon and password. We have almost 70 providers, and so would I have to assign one to each of them, or can I have a general password?
Why don't you send us an email, because I'm not sure about the answer to that. Yeah.
All right, I'll do that.
I think that we would have individual passwords, but send me the email and we'll look into it.
Okay, thank you.
Okay, to that general email address. We'll monitor that box.
Okay.
Thanks.
Thank you. Our next question comes from Pamela Pop. Your line is open.
Hi. As we move down the electronic healthcare record path, providers are wanting to access the electronic healthcare record maintained by the FQHC from their home PCs, or they want us to provide them with PCs so that they can have access when they're not at the office. I have some concerns, security, HIPAA privacy, et cetera, but what has your experience been, and what are other folks doing regarding this particular decision?
Hi, Pam.
Hi. How are you?
I'm fine. This is Kathy. What a great question. I don't see the health centers having any different requirements than any health facility with regards to, encryption and security and HIPAA protection.
Right.
If you're using firewalls and you have, it has to be established to protect that information in transmission, and in both ways, whether you're transmitting information to the record, whether it's sitting on a server at the health center or whether it's a piece of software, it absolutely has to be protected. There's really no different requirement for any health center or any provider, whether that's at a health center or any health facility.
Yeah, the Starbucks wireless network stuff bothers me.
Absolutely. And we talked yesterday on one of these calls about the providers, going home at midnight and finishing their records. Number one, that being rather removed from the actual encounter, with those issues. But the second issue is exactly the one that you're posing, and that is that in a secure environment.
Yeah.
So, Ann, do you have any thoughts?
No, just for those who, I've worked with some organizations where there is a small group of people they will allow to have remote access, and that all of their laptops are encrypted, of course, so that does need to be minimized. But I think one of the issues, as Kathy already mentioned, but again, is, the person who didn't quite get to finish their charting before they left for the day because they know they can do it at home, and then it may or may not get done. So lots of caution goes with that process. And hi, Pamela.
Hey, how are you?
Good.
Again, it's imperative that their planning and implementation have to consider this, and they need to work with whatever vendor and their information technology support to ensure that that's part of the planning and implementation process.
Those are good recommendations. Thanks.
Thank you. And our last question comes from Gerda Palasant. Your line is open. Gerda, your line is open.
Yes, I would like my provider to access the email as well so they can go over it.
Okay. Would you be able to send us or call us, send us an email or call us with your information?
Sure, I'll do that.
Okay, that would be great.
All right.
Thank you. You have the contact information?
Yes, I have it on my screen right here.
Okay, excellent.
I'll email you and then get my provider to access it because it will be interesting for them to have those information.
Wonderful. Thank you.
You're welcome.
Okay, well, in that case, thank you, everyone, for joining us, and we will conclude at this time. Have a good day.
Thank you, and that concludes today's conference call. You may all disconnect at this time.